Welcome to this talk, and welcome back to Dr. Josh Getsko from Hebrew University in Jerusalem. Now, thank you for coming back, Josh. The last time we talked, it was about DNA contamination and bait and switches, wasn't it?
Yes, that's right.
Which was another appalling story. I wanted to do this for two...
It's a while ago.
Yeah, but sadly the situation hasn't changed too much. There's two reasons I wanted to do this. The first is the really quite surprising rates of fetal loss. COVID-19 vaccination with first dose during weeks 8 to 13 of pregnancy. We get, when we compare the expected fetal losses versus the actual ones, after vaccine, we get 13 versus 9 for every 100 exposed pregnancies. That's 3.85 additional fetal losses to be expected per 100 pregnancies. Quite incredible. And the other reason I wanted to do it was that this data has been analysed in Israel by you and a very prestigious team on an anonymised basis, and it could be done all over the world. But am I right about the sort of headline figures there, Josh, basically?
Yes, that's exactly right. We rounded up, we say there are about 4 additional fetal losses per 100 pregnancies for women who vaccinated with a COVID vaccine for the first dose from weeks 8 to 13. That's basically like the first trimester, but for various reasons, we only start looking at the women at week 8, and we can talk about why that is at some point.
The vaccines in Israel were almost entirely Pfizer, were they?
Yes, that's right. The government came to an arrangement with Pfizer where they would open up the country and the country's health data for analysis by Pfizer, work with it to publish and look at the real world effectiveness of the vaccination in exchange for priority in getting doses to the public. So we were among the first countries to really vaccinate almost, a large percentage of the population. About a month after they started vaccinating the population, they recommended that pregnant women in their second and third trimester be vaccinated. The reason that they didn't recommended for the first, they didn't have any data to suggest that it was safe. They didn't have any data that particularly suggested it wasn't safe, other than women complaining, lots of complaints about menstrual irregularities. But the reason they didn't say that recommend it for the first trimester is because there are so many women who have miscarriages in the first trimester. They didn't want a coincidental connection to form in people's minds and give the vaccines a bad reputation. But it only took them about 2 weeks to change their mind, because by February 1st they were recommending it for all women at all stages of pregnancy. And it's absurd because we don't, we protect pregnant women. We don't want them to eat sushi, take ibuprofen, right? There are very few medications, right? There's so many problems that can occur in a developing fetus, especially in these early part of pregnancy. And, so the precautionary principle was just completely thrown in the trash bin, or as you guys say, the rubbish bin. And here we are, a few years later, learning that it really had a very serious consequences.
It really is quite incredible, the almost cavalier approach taken internationally with prestigious bodies of doctors and midwives saying, no, take this vaccine in pregnancy. And as you say, I've taught this for decades. We don't let pregnant women clean out the cat litter. We don't let them eat soft cheese. We don't let them eat certain types of pate. Right. We tell them not to eat tuna with mercury in it.
That's right.
We're so careful, and in clinical practice we are
right. But you can inject them with experimental gene therapy, no problem.
Right. In clinical practice, we're so careful. Even senior consultants I've worked with, every single drug they give, very often they'll ring up the obstetricians and make sure it's all right if there's the slightest doubt about it.
Yeah.
And I think the other thing is the clinical trials. Pregnant women weren't really included at all, weren't they, in the original clinical trials?
They weren't included. They were excluded. If they had to took a pregnancy test when you first signed up to see if you were eligible. men who were in a relationship where they were thinking of conceiving weren't supposed to get the weren't even supposed to be vaccinated. And interestingly, after all of that went on, right, after the trials and everything, they did start a trial. Pfizer did start a trial on pregnant women. They only ended up recruiting about 170 women, and only starting at week 24 of pregnancy, basically only in the third trimester. And so and most of the other research that's been done on the safety of the COVID vaccines in pregnancy has been done on later pregnancy. What happens when you get it later in pregnancy? Much less research on early pregnancy, and that's one of the reasons that we focused on that period.
Indeed. Now, you actually took data from 2016 to 2022, so you had some good pre-vaccine years to form baselines from. And 226,000 pregnancies in the study. Is that the total amount of pregnancies throughout the 6-year period?
That's the total amount of studies in a 5-year period. So we looked at we have 2016 to 2018 in the study. We do a validation in the year after that. Then we skip a year because that's sort of when COVID started hitting, and then we look from. Well, it's when some women, their pregnancy might have been affected by COVID, and then we start sort of early 2020 until early 2022. That's the main period. And there we have, I think, about 100,000 pregnancies if memory serves.
Yep. And
is that right? 80,000 maybe.
That's still a very substantial number, isn't it? You can get pretty hard data out of those kind of numbers.
Oh yeah, absolutely. Absolutely.
Statisticians will be watching
this data, look, I hope so. I mean, the data is really high quality. This is high quality electronic medical record data from a major Israeli health insurer. And I want to take a moment also to point out that among our collaborators on the paper were 2 senior researchers working with the Maccabi Health Services research unit, who arranged for us to get access and worked with us on analyzing the data. Very esteemed people, and we're indebted to them for making this happen. And also, another person we have from Maccabi on the paper is the head of the OBGYN services at Maccabi, a very senior doctor who's read the paper and believes that the findings should be made public and are concerning.
I will actually flash up the names of all the authors. It's a very prestigious group of prestigious group of doctors and academics with international reputations.
Yes. Yeah, we have Tracy Beth Hoag, and actually I'm not sure how to pronounce her last name, who is now working at the FDA, and she's done really great research on studying a lot of the COVID measures that were taken, like masks and that sort of thing. And Joseph
Freeman. Joe Freeman.
This is Freeman. Thank you, Joe Freeman, who did this reanalysis of the original trials and had it published, showing there was a higher serious adverse event rate than most people. You've talked about that paper. So we have really solid.
It is. It's a very solid piece of work. Is this
and of course Retzef Levy, who's now on the ACIP committee, the Advisory Council on Immunization Practices at the CDC. Yep. So he's also.
Yep. I was going to say, is this observed versus expected comparison a standard sort of research tool that you use?
Yes. So let's get into that a little bit. So observed to expected is a very common tool for adverse pharmacovigilance, meaning analyzing the potential adverse events that occur with medical interventions, including vaccines. So, for example, at the in August 2021, the CDC presented to the FDA their analysis of the VAERS system on myocarditis, and they used an observed to expected. And now, what is observed to expected? It means that you look at some period after a vaccination, say 3 weeks, and you say, after 3 weeks, how many events of this adverse event, how many cases of myocarditis did we observe? And based on historical precedent, how many would we have expected to see among that population in that 3-week period? And what they found at that time was there were way more cases of myocarditis that they observed than what they expected. So the problem with the way that this analysis is usually done is they generally only kind of adjust for age or sex. So it's a very kind of broad brush course adjustment when you want to look at observed to expected. And the innovation in our study is that we're using individual level, detailed individual level data, and we build a model, a statistical model, using data from the period 2016 to 2018 to predict for every woman who's pregnant, based on her individual level characteristics like her age, her smoking status, comorbidities, all this stuff, okay? So based on that, based on the calendar timing of the pregnancy, and based on the gestational week of pregnancy, we can predict for every woman what is the probability that she is going to lose the pregnancy at some point, okay? And then we basically apply that statistical model to the women in the COVID period. And we say, okay, well, based on this historical model, if you have these characteristics and you're in your 8th week of pregnancy and you conceived in February, then you have this likelihood, this probability of losing your fetus. So then we can estimate the expected number of fetal losses for women in any given week of pregnancy. We can say, okay, you were vaccinated in week 8, right? We take all the women who were vaccinated in week 8, we say, based on these women's characteristics, how many fetal losses should we have expected to see? And then how many did we actually see? And that's the trick. So we do this observed to expected, and that's where we get to this almost 4 additional fetal losses that are observed above what was expected. And I want to go one more step beyond that and say that another startling finding, I think, from the paper, it startled us at least, is that many of these fetal losses don't happen early on. They happen much later in pregnancy. So women vaccinated in this early period, about a little bit over half of the fetal losses occurred from week 20, right? So now they're defined as actually as stillbirths. And almost half of them occurred from week 25.
Very late, isn't it? Very late.
Yeah, it's very late. It's very late. And
so
one of the reasons that we did that analysis,
vaccines given 12 weeks before, more than.
Yeah. Yes, exactly. And that may be one of the reasons why nobody picked up on. One of the reasons we think nobody picked up on this signal is because it's spread out over the pregnancy. So it's not obvious that it's related to something that happened weeks or months ago. And then also, most of the research that's been done on this differentiates between those two periods, early and late. And so if they're looking at early pregnancy, they'll only follow the women to week 20. And so they miss a huge portion of the signal. And if they're only looking at vaccination later in pregnancy, they're not going to pick up on the signal because it's from the vaccinations that happened earlier, right, that's causing this. So you can kind of start to see why this signal was missed in existing research. One more thing I want to add. The reason that we looked at later in pregnancy is because our measure of fetal loss includes both miscarriages and stillbirths and also induced abortions, some of which can be elective. Some people said, well, maybe it's just elective. Women were worried, it was COVID period, and they decided to have an elective abortion. And that's why we started looking at the later period, because in Israel, after week 20, the number of elective abortions is tiny, and after week 25, it's essentially non-existent. There's all these regulatory things you have to do, even to get an induced abortion. If there's a problem with the fetus or endangering the mother's life, you still have to go through this process. People aren't getting elective abortions later in pregnancy, and so we can say without a doubt that most of this signal cannot be attributed to elective abortion.
It's really a very impressive technique. I was smirking earlier on, just wondering what sort of statistical package you could be used for including all these variables in the analysis. I don't want to know that, right, because I probably won't understand it. But what the bottom line is, basically what you've done is you've generated like an individualized person for person, woman for woman control group with essentially the same characteristics. So in a sense, you've got a huge experimental group and you've got a huge control group.
Yeah, that's a good way to think about it. That's a very good way to think about it. But we do something else, because people will come and say, well, look, the COVID period was so unique. How can you compare women in this earlier period to women in the COVID period? So we do a few things to check that, okay? One, that's one thing we told ourselves, right, when we're doing the research. So one of the things we did is we looked at women vaccinated for influenza in the COVID period. And what's interesting about that is we found exactly the opposite trend, whereas women vaccinated with COVID vaccines in that early period had a higher than expected fetal loss rate. The women who were vaccinated for influenza had a lower than expected fetal loss rate. And if you don't mind, I'd like to show a graph that kind of illustrates this. Would it be all right for me to share that with you?
Let me just see if I've got it here. I think we should probably point out, first of all, do you think it was the influenza vaccine that was preserving the pregnancies, or is there another effect going on here?
Right, that's a good question. So we don't think that it's, so in principle, it could be a protective effect of the influenza vaccines that's protecting them from influenza, and therefore they have a lower than expected fetal loss rate throughout the entire pregnancy, by the way. Okay, this is the, oh, okay, you're showing that one. Okay, great. So this shows the COVID vaccine dose. So you see this black line, the black line is the observed, and the dotted line is the expected, and then there's these error bars that show you when it's not, you can't attribute it to chance. And so what we do is we basically average, if you look at the x-axis shows us in what week was the woman vaccinated, yes. Okay? And then it shows us among those women, for every 100 women vaccinated in that week, what was the number of observed to expected fetal losses per 100 pregnancies. So here you have, if you were vaccinated in week 9, the expected number of fetal losses we would have seen, we expected to see, is about 14. We know it's 13. It's about 13 per 100. And what we see is something more like 22 per 100.
It's a huge increase. Now increase, isn't it?
It's a huge increase, and if you average over the first trimester, weeks 8 to 13, that's the last part of the first trimester, that's where you get your 3.85, above expected. So you're averaging, but that doesn't mean it's the same for every week. Some weeks are worse, some weeks are better. And then when we get to week 14, the trend switches, and then we see kind of a lower than expected, although it's kind of very close to the error bars. It might be due to chance. But what we see, if you can show the, I don't know if you have the influenza vaccination. So here we have the influenza, and then you can see it's switched, right? So you see that the observed is much lower than the expected, and it's much lower throughout the entire pregnancy. And so this could be the influenza vaccine protecting women from influenza and protecting their babies, and that's why they get that. We don't think that's what's happening. And the reason we don't think that's happening is because we looked at this exact model from an earlier period, 2018 to 2019, and when there was a heavy flu season, and we see almost the same exact reduction, okay? But in the COVID period, flu kind of disappeared, right? The extent of flu was very low, especially in one of these years. We've looked at the year, by itself, and essentially, so you have basically the same association with lower than expected fetal losses in a heavy influenza season and a non-existent influenza season, and it has the same difference. And so you can conclude that it's not about protecting women from influenza. In fact, no study has shown this kind of protective effect of influenza vaccines. What it probably shows is what's known as the healthy vaccinee effect, which means or healthy vaccinee bias, which is basically because healthier people on average, health-seeking people who are conscientious about their health, people who go to their doctor, are more likely to be vaccinated. And so when you're comparing women who are vaccinated and women who aren't vaccinated, you have to take into account the healthy vaccinee effect, but it's a very difficult thing to measure. Okay, you can measure women's comorbidities and how kind of healthy they are, but this health-seeking behavior is kind of nebulous. It's hard. I have a friend who every year when he wants to renew his health insurance, he has to fill out a survey, and they ask him, "Do you floss your teeth?" It's not because he has a dental plan. it's a way, it's kind of an indication for them, is this somebody that takes care of themselves? And in particular, what we're seeing here with this healthy vaccinee effect is that for pregnant women, it seems to be kind of time dependent or dynamic, meaning it's sort of women whose pregnancies are healthier and doing well, they're not having bleeding, they're not having problems, are kind of more likely to go out, and women who are, having problems with their pregnancy are less likely to go out and get vaccinated, we think, right? Because, for example, this model that we have, when we look at women who were vaccinated prior to pregnancy, when we look at unvaccinated women, when we look at all women, we see that our model, the observed to expected, is basically the same. Okay, it's very similar. But when we look at these interventions, this vaccination during pregnancy, that's when we see these offsets, and that's one of the reasons we think this healthy vaccinee thing is also kind of time dependent. But maybe I'm getting a little bit too deep in the weeds here.
No, I think that makes perfect sense. So we know that people who had the influenza vaccine, they have better pregnancy outcomes, basically. But we don't think that's due to influenza, because when there was a huge amount of flu around, that they didn't get increased protection. The level stayed the same.
Right.
So these are probably women that are basically looking after themselves. And the other thing that whose
pregnancies are doing better.
Yes, indeed.
They don't have any alarming signals from their pregnancy.
Yeah. And the people that took the COVID vaccine prior to pregnancy did not have an increased rate of fetal loss. It was vaccination during pregnancy that seems to be the risk.
That's what
in terms of fetal loss.
That's what we're finding. That's what our findings suggest. There's more research to be done. We'd love to have our findings. I don't know if you need the graph on the screen anymore.
Yeah. No, I can take that off.
So, okay. Yeah. And so another thing is that existing research has generally compared vaccinated women and unvaccinated women in the same time period during the big COVID drive. And doing that comparison will tend to exacerbate the healthy vaccinee bias. And so essentially what you end up comparing is women who vaccinated, who tend to be healthier on average, to women who didn't vaccinate, who tend to be less healthier. There's something going on with their pregnancy and so if you find that there's no difference, it's actually a concern, because these women who are healthier, right, should be doing better. And so far the research has just essentially shown no safety concerns. But we think that they haven't done a good job of dealing with this healthy vaccinee bias, especially if it may be a kind of time dependent thing.
Yep.
So this is another reason we think existing research has missed this signal.
So the women that were vaccinated before pregnancy, of course, they had all the other risks associated with vaccine, the myocarditis and the thromboembolic complications. I mean, that we're not looking at that.
Right, and because we don't look at the period in early pregnancy, because the reason we don't look at earlier in pregnancy is because some women aren't under doctor's care or follow-up. And there can be biases introduced in the way that the tendency of women with certain predispositions to report. So, for example, a woman who goes out and gets vaccinated is in touch with her doctor. And as soon as she knows she's pregnant, she's going to be in touch with her doctor. And if she has a miscarriage, she's going to report it to her doctor. And so you have to kind of wait until almost all the women are under follow-up before you start looking at this, to avoid that type of bias. So that's why we don't do that. So there could be things going on in earlier pregnancy. It could be that women, we don't know, and maybe I probably shouldn't even speculate on this. It's conceivable that women vaccinated earlier are seeing issues earlier in pregnancy. It's not being reported. We don't know 100%. But this is a limitation of this type of data. It's just sort of inherent.
But what you do know. The first vaccine dose dose during weeks 8 to 13, 3.85 additional fetal losses to be expected per 100 pregnancies.
Well, okay, now that we've gone through the healthy vaccinee effect, think about this as a possibility. If the women vaccinated early for COVID are similar to the women vaccinated for influenza, and we think they are, and we talk about that in the paper, then the baseline maybe shouldn't be the expected, it should be the observed number among the influenza vaccinated. That it should be the women who vaccinate for influenza, because they're more like the COVID women, they should be the baseline. And in that case, the number of...
And you're comparing healthy vaccinee effect with other healthy vaccinee effects.
Exactly. And so, but then if we do that, then that means that it's not 3.85 or 4 additional, it's almost 9 additional fetal losses.
Really?
Right? Which is,
it's just,
which is,
that is, it's an even more frightening number, isn't it? That's, so implications from this, I think are covered really nicely in your conclusion. I mean, this needs to be taken on board by regulators, doesn't it? I mean, and by the Royal College of Obstetricians and Gynecologists, who last time I checked a couple of weeks ago was still recommending pregnant women get vaccinated based on, as far as I can see, essentially no trial data. There's no good clinical trial data for this. That's for sure. There have been a lot of observational studies, and so I can imagine a well-intentioned doctor looking at this. There's meta-analyses done and that sort of thing, and instead of sort of getting into the weeds of the research studies, understanding the limitations and the potential biases and whatever, they just that's the party line, and why would they question it? And so one of the things that we would like is for this research to be more widely known and recognized, and for additional follow-up studies. If doctors could be made aware of what the potential biases are in the existing research and what our research shows, hopefully, they would think differently and act differently. Indeed, and I've talked to a senior people in this country, a senior politician, and he assures me it's quite possible, the way the NHS data is arranged, to completely anonymise it. So the number in Israel was 3.9, basically, or higher. What that increased fetal losses per 100, what that number is in the UK, we don't know, of course, because we don't know the data who was vaccinated and who wasn't. And the same for the United States. But that data is there and can be anonymised.
Yes.
And it's not. And this is what is intolerable. We are not. So you've worked out that number for Israel. Well done, you and your team. For the UK, we don't know. But let's suppose you get a phone call this afternoon, because I'm fairly well politically connected, you probably realise. Let's suppose you get a phone call this afternoon from, I don't know, someone called Keir Starmer or someone like that. And he says, look, Josh, we've anonymised this data. It's all here. Could you plug these numbers into your existing system and do the calculations for the UK?
I wouldn't plug the numbers into the system, but we could run the same analysis on the data in the UK, and we're actually in the process of working on a replication study in Canada using Canadian data. So we'll see where that leads. One thing I want to stress is that we didn't come into this trying to show something.
Of course not, no.
Okay. No. And in fact, we took every possible effort that we could in order to make it go away, right? To disprove this, because we sort of saw it very early on, the way we were approaching the analysis with. And we just, we threw this at it and that at it, and we pulled it and twisted it, and we just did everything we could to try to make it go away, and it doesn't go away. It's a very, very robust result. And many of the things that we tried actually made it look even like a bigger difference than what we found. So, it is what it is. And but we're, none of us on the paper would have signed our names to such a controversial finding if we weren't 110% certain that this was a robust finding.
And that does shine through on the paper, that this was a genuine inquiry. It wasn't trying to prove a particular point. And indeed, I'm sure many members and writers are distressed by the results because of the implications of it for pregnancies.
I think one other thing I want to bring up is that, and then I have to go, is that we have... So it's a number of other people throwing out these numbers, 81%, 82%, 86% miscarriage rate after COVID vaccination. And our study points to something much lower than that, still extremely concerning, but it's not 86%, which is, if that was really the rate, it would be completely unmissable. Nobody, no one would question whether there's any safety concerns here. Those numbers are based on an erroneous misinterpretation of both. There's a Pfizer report and there's some FDA study. We could get into the details of what it is. Basically, they just miscalculating the denominator and coming up with this 86%, 82%, 81%. Those figures are wrong. We've tried to talk with the people using those figures. They won't listen to reason. But hopefully your listeners will.
Indeed. And let's just close on the point that your methodology is sitting there. It's like a tool on the bench. The British government could pick it up. The Canadian government, the Australian government, the New Zealand government, the European Union could pick it up, use this tool and get these results for our respective countries. But sadly,
absolutely. I would be happy to work with anybody who wanted to try to replicate this, to try to understand the nuts and bolts of how the analysis works.
Do check out the study for yourself. To be quite honest, it's not an easy read. That's why I wanted to do this. But the results are concerning.
So I have a summary written up, more kind of easy, more accessible summary on my Substack, researchrebel.substack.com. So that would be another place people could go if they were having trouble navigating the paper itself.
We'll find the link. Yeah, but the main points are sufficient to give concern. If regulators ignore this, then in my view, they're simply not doing their job. But for now,
agreed.
Josh, as always, and you and your team, thank you very much.
Thank you.